Welcome to our podcast, Living Our Best with Memory Loss. What makes this podcast unique is that three of its hosts, Bob, Dennis, and Sue Ann, have a memory loss diagnosis. The purpose of this podcast is for people to share their experiences with cognitive decline. It is not to provide medical advice. We are not doctors, and we stress that what might have worked for one person might not work for others. If anything you hear on this program inspires you to explore treatment options, we recommend you do so in consultation with your physician. This is part one of a two-part episode with our guest, Dr. Catherine Madison.
Welcome to today's podcast, Living Our Best with Memory Loss. We're very pleased to welcome Dr. Catherine Madison from San Francisco. She is a neurologist who specializes in the holistic care of those with dementia. Dr. Madison is the founding director of the Ray Dolby Brain Health Center, and we welcome you to our podcast today, Dr. Madison.
Thank you very much for having me here today. It's a pleasure to be with you all. I love this topic.
We love that you agreed to do this. You're 3 hours behind us, so you're on Pacific time, so we're flattered that you would make the time. Dr. Madison, today you were going to talk about the basics of dementia. What do you mean when you say the basics of dementia?
Well, first off, I, over the years, have met many individuals who, when I will say to them, you have a vascular dementia, they will say back to me, oh, well, thank goodness it's not Alzheimer's disease. And that is accurate in that generally a vascular dementia can follow a much slower course. But I think people tend to miss the concept that vascular dementia, frontotemporal dementia, Parkinson's dementia, Alzheimer's disease, they are all a dementia. So understanding the concept of what a dementia is, a neurodegenerative illness, which damages your brain to the extent that you need assistance in day-to-day activities. And so I think we all need to understand that it's an umbrella term. Dementia is an umbrella term that covers many different types of diagnosis, and people need to understand that.
Right.
The basics also, I think, include why you should get to a doctor and get an evaluation, because there are some treatable conditions that can mimic a dementia. Some other basics include normal changes that we have in our brain with aging. It's also basic for everybody to understand how a diagnosis is made. I've said over the years, it's not like a pregnancy test where you just can get a positive or a negative, although it's getting closer to that, certainly with the blood tests, which are becoming available now. But I think those are all some basic concepts of dementia that the general public benefits from a better understanding of.
Dr. Madison, also, people often say or ask me, and I would love, you're the expert here, with a diagnosis of dementia, does that necessarily mean that it is going to evolve into Alzheimer's?
No, not at all. Again, dementia simply means there's damage to the brain, so it can't function independently like it used to. Alzheimer's is one of the many neurodegenerative conditions that can cause dementia. You can have dementia from head injury. I mean, you can have dementia from a lot of different things. Alzheimer's is the most common cause of dementia. That's why it's talked about the most. Okay, so why don't we talk about what a dementia is? A dementia is a neurodegenerative condition with many possible underlying abnormal changes in the brain. So it can be caused by different things. The symptoms of a dementia include things like short-term memory loss, poor judgment, changes in behavior, loss of language skills, or impairment of complex abilities or executive function, which we use in our everyday activities in keeping our life organized. Alzheimer's is the most common type of a dementia. It's important to understand that because there are so many causes of a dementia, getting an evaluation to look for a cause that can be better managed or potentially treated is critically important. So now that we have covered dementia is a category or an umbrella type of a diagnosis, we'll just touch on the main causes of a dementia or different types of dementia. And Alzheimer's is the most common, a good 60%. Some people say 70%. And the prominent difficulty in Alzheimer's is the loss of newly formed information or new memories. However, it can present different ways. It can affect language, it can affect behavior, but most common and prominent is that loss of newly learned information. Lewy body disorders are also common, and this is a Parkinson's disease dementia or actual Lewy body disorders. This is a different abnormal protein that collects in the brain. And what is characteristic about this type of a dementia is slowed movements and impairment in visual spatial abilities. This relates to the abnormal protein being deposited in different areas of the brain. In the Lewy body disorders, the protein tends to be deposited in those brain centers, which help us coordinate movement and also understand images in our brain. So people with a Lewy body disorder can have frequent falls. They can have difficulty navigating. Then there is a vascular dementia, which is when you have an excessive burden of those white matter lesions or small strokes causing so much damage to the brain that a person can't function at their normal prior level. And that then becomes a vascular dementia. Another major category of dementia is the frontotemporal lobar dementias. The frontotemporal lobar dementias have abnormal tau accumulate, and they often involve the frontal regions of the brain. This is a particularly difficult type of dementia because our frontal lobes are closely related to our behavior and inhibition. And so you can have a lot of behavioral problems in patients with the frontotemporal dementia, as well as significant changes in their ability to communicate. Important to recognize here is that it's usually not one change going on in the brain. To make it more complicated, the changes or pathology tend to be mixed. In some autopsy studies that were done on individuals with an Alzheimer's disease, a good half of them, when you looked at the brain under the microscope, actually met the criteria for a vascular dementia under the microscope. But what was being seen clinically and how they acted and how they performed on testing looked more like Alzheimer's. Lewy body pathology is probably second most common to vascular damage and is mixed in with a lot of the other dementias as well. So we label the dementias based on what is the most prominent pathology or change in the brain and the features that we see clinically, as well as the findings on neuropsychological testing and brain imaging. It's not as straightforward as we'd like it to be.
So where does mild cognitive impairment come in?
Mild cognitive impairment can stand as a mild cognitive impairment for 10 or 20 years, or it can become worse and become a dementia. Any one of those dementias tends to start as a mild cognitive impairment, because a mild cognitive impairment simply means that your brain isn't functioning at full capacity based on formal testing, but it isn't impaired so much that you need assistance in your day-to-day activities.
I see.
Did I answer your question?
Yes, very much so.
The way that I understand it is the mild cognitive impairment is a measurement of where you are on the continuum of due to any cause. Like what she just what she just listed were the causes of those, and they can be measured. Okay, this person may have Lewy body, but they're still in the very early stages, and it's affecting them with mild cognitive impairment. But as it progresses, it will leave that category and move on. So it's more a measurement of function rather than a cause. Is that correct? Am I saying that correctly, Dr. Madison?
Absolutely right.
Yeah.
It's a measurement. And formally, it's a measurement based on neuropsychological testing. I think it's helpful if we can look at some images of the brain. I'm sharing here some MRI images, and the first one is called a sagittal image of a normal brain. Sagittal image means we're going from front to back. So you're literally looking at a slice of the brain going from front to back. That image is of a whole head. And so, I mean, you can recognize there the nose, and that there's a great big area in the front there, which is the tongue. The tongue is a massive muscle, but you see the brain above that. And you'll notice on that brain that there are what we call convolutions, or the surface folds in on itself. That's so we can get more nerve cells in there. The nerve cells are predominantly located on the surface of the brain, and it folds in on itself so that we can get more and more of them in there. You can take a human brain, and if you laid it flat, it would be as big as the New York Times laid open, the surface of the brain. But it's all folded in on itself to fit in this small space. It's economy of scale, right?
Right.
So that's a sagittal image of the brain. The cells are on the top. White matter tracks connect those cells on the surface to other areas of the brain, down into the brain stem, and down into through the spinal cord into the muscles of our body. Those white matter tracks are a very elaborate system. On our next slide here, we actually see those white matter tracks in color. A lot's been done in imaging, and so it's gotten more exciting, but it's also good for research. We are discovering a whole lot. And so what we have here is a colorized image of those white matter tracks. So if you think back on the previous slide, for all of those surface area of the brain folded in on itself, you have these track systems connecting to other areas of the brain, down to the brain stem and into the spinal cord. It's really beautiful, isn't it?
Yes.
So the next slide shows a cross section of the brain. So we're looking at it, a slice taken like this. And we look at it that way just because it gives us a better view of the track system from on top, so to speak. And what you can see there is the general gray area of the brain, and you can see white spots. Those white spots in the brain were discovered when MRI scanning was discovered about 30 or so years ago. When it first was discovered, I was in my residency, and they were actually called UBOs, standing for unidentified bright objects, because we had no idea what they were.
Sort of like UFOs.
At first, we didn't know what those bright objects are. They're being studied extensively. We know it relates to oxidative stress. The cells in that area simply aren't getting as much oxygen as they need. They're in distress. Some of them may actually die, but they're not able to function properly. As we age, we all tend to, we can all collect those white matter hyperintensities, or those little bright objects in the white matter. It's like we develop spots on our skin. We don't see it, so we're not aware of it. The more of those white matter spots, we call them lesions, that one develops with aging, the more likely it is that messages traveling through that elaborate colored system that we saw previously, messages might get delayed, might get stuck, or even lost. So it's good to have these concepts down visually. I think it helps us better understand what's going on with our brain with aging. It also then helps us understand when there's a neurodegenerative process which is causing even more damage. those white matter systems and all of those networks break down.
So is it necessarily true that if the more white spots you have, that is more of is that necessarily related to a dementia or a memory loss, I should say, a memory loss diagnosis?
There's a lot of research going on around that question, Lori, and the answer does appear to be yes, there is clearly a relationship, and the accumulation of more white matter lesions is associated with more cognitive decline.
The location of those spots, does that also determine if it's frontal?
Absolutely. Yeah, it does. The location of the spots is critical. The brain is like real estate. Location, location, location.
It does. Yeah, that's a great way to put it.
And does anybody know the reason that it starts to deteriorate like that?
So there are risk factors for getting more of those white matter spots or lesions. Number one is age, but number two is genetics. If you have a tendency towards high blood pressure, high cholesterol, diabetes, if you're a smoker, if you're not exercising enough, and other things contribute to the risk of getting more of those white matter lesions, Bob.
I think I have all the above.
Yeah.
Managing risk is one of the most important lessons emerging in trying to prevent a dementia or kick it down the road and delay its onset. It's believed that maybe 50% of the risk factor for dementia is manageable, and they keep coming up with more and more factors in that list of manageable items.
But there still is a genetic component that is the greatest indicator that if dementia is a family trait, it's more likely that you'll exhibit this as well.
You are right there, Dennis.
Okay.
Genetics are an important factor. There are certain types of dementia which are genetically determined, particularly the early onset ones, but I'm talking about early onset like in the 40s and 50s, Dennis. And so those are genetically predetermined with dominant inheritance, meaning that someone has a 50-50 chance of getting them. Other genetic factors, though, are involved, and people are still trying to sort through all of those. The more direct family relatives you have with a diagnosis of dementia, the higher your risk. That is correct as well.
When should someone see a neurologist, Dr. Madison? You know, we made a comment earlier that we all forget where our keys are. We all forget, to turn off the lights. I remember Dennis once said, and it resonated with me, he'll say, we all go into a room and say, oh, what did I come in here for? And then Dennis said that, yeah, but I used to do that, but I went into the wrong room. I went into a bathroom and was like...
To a closet.
Through a closet. And
Right.
so when does somebody recognize that it's not just old age or it's just not common that I forgot my keys, or when is the time to really turn to a neurologist?
That's a really good question, Lori, and no one has a straight answer on it. Some people advocate for getting formal neuropsychological testing, which is detailed neuropsychological testing over 3 hours or so when you turn 65. I recommend it a lot for people I see who might be in their 70s who just have concerns about items like misplacing their keys or walking into the wrong room. And another time to see a neurologist is when there is a disparity in a couple in terms of perception on change. So one person might feel that everything is fine, but their partner is really seeing changes, you should definitely get an evaluation then. And we can talk about that more later when we talk about anosognosia.
I think you referred to a very common situation where the person, in my case, my story is that I knew that it was more than just forgetfulness. I knew that. And yet there's some trepidation about putting a label on it. And yet I knew, and then I would have friends that would talk me out of it. Oh, I lose my keys. I do that too. And they kind of minimize it because they don't want anything to be wrong with you either, And then I did have a heart to heart with my spouse, and it's like, yes, I'm seeing this, I'm seeing that.
I think a lot of that, Sue Ann, relates to stigma in our culture. We're all terrified of this. I look at a dementia as the ultimate existential crisis because I honestly can't think of anything more terrifying and anxiety provoking than a neurologic illness that's going to silently steal your independence and ability to take care of yourself on a day-to-day basis. That is a true existential crisis. And because we don't yet have cures for it, we're all terrified of it, all of us. And I'm a big advocate of planning for if I have it, because that's the only way that I can feel more comfortable continuing to operate in my world on a day-to-day basis. My mother had it. I'm at increased risk. There was another study recently that when your mother has it, you're higher risk. Women are higher risk. We look at all those things, but advocating for yourself and getting the testing is the right thing to do.
Well, and I really like the way you talk about, and some of the other things I've seen you share with other podcast people, is normalizing it as part of both what you expect, and like you were saying, in your 60s and your 70s for that benchmark, and normalizing it as this is just something we do as part of our self-care to take care of ourselves and know how to plan. And I love that approach that you have, and I think that refers back somewhat to your holistic belief and looking at the whole person and their whole environment.
Absolutely.
Dr. Madison, is it a bad attitude? There are folks who turn around and say, I don't want to know. You know what? I'm going to take life as it goes, and if it happens, it happens. But isn't that, I know everybody's different, but isn't that kind of a wrong way of thinking, in that if you do get tested, there's like Ariceps that you can immediately go on that can stave off the disease to a degree? I mean, so is it the wrong attitude to be taking, you know what, I'll take it as it goes, that if you're having some sort of inclination that your memory's declining or there's a problem, should people move forward and get tested because of those medications that are available?
So you've got a lot of things in your question there, Lori.
If you can speak, Lori, for just a moment, good luck to you with that.
So if people don't want to know, again, I can understand that. And that, I think we should allow people to follow that path if that's what they choose, as long as they have planned accordingly. So it's absolutely not okay to say, I'm not going to worry about it. If you, for instance, are working as a nurse and can make a mistake that could harm a patient. Exactly. What I see much more commonly, though, is people who don't want to look into it, and they haven't set up a will, they haven't set up a trust, they haven't set up durable powers of attorney. And that then is disastrous for loved ones down the road. So from that angle, it's not okay. Just plan like you might come down with it. Then you can do what you want. So, getting back to your question about medication, Lori, there are indeed medications now available that can dissolve the amyloid plaques which develop in Alzheimer's disease. So, the newest one, donanemab, it's a monoclonal antibody. And if it's used in patients very, very early in the course of an Alzheimer's disease, a mild cognitive impairment, it might actually arrest decline. So research is ongoing. The research is already out that this type of medication slows decline by a good 30% or so. That's a lot.
That's impressive.
So that means someone at, let's see, how can I make this comparison here? So that means at 18 months, if you've got two people, one who's on the monoclonal antibody and one who's not, the person who's on the monoclonal antibody will be at that 12-month point versus the other who's not and is at 18 months into the course of the illness. So getting a diagnosis has become critically important because if it is an Alzheimer's process and it's very early, there is treatment which can slow it down and may even keep it at bay. Don't know. Jury's still out on that, but it's hopeful.
Dr. Madison, I just want to thank you so much for your time and your expertise, your commitment to this subject. And I know that you mentioned that it's personal to you, and we appreciate that so much. And we thank you for being with us. We know you're going to join us on our next episode. So thank you again for being with us.
You're very welcome. It's my pleasure.
Thank you. Thank you from all of us.
Thank you for listening to Living Our Best with Memory Loss. Please tune in again next week as we finish our conversation with Dr. Catherine Madison.